And good afternoon, everyone, and welcome to PerfWeb 98, Day 3. Today, we're going to be hearing from Dr. Patel. You saw him in the ECMO course if you took that, and I'll introduce him here formally in just a moment. I'm here with my colleague and great friend, Vicki Carlisle, who is the director of our nurse adult ECMO specialist program, and also our director of education here at MediWeb and PerfWeb and NurseWeb and all of those other webs that we have. Webs. We have lots of webs. With that said, contact us at Perfusion Education, contact at perfusioneducation.com, right down there. Call-in number if you'd like to ask Dr. Patel a question live, 832-239-5358. It's 832-239-5358. Keep your eyes open for our scroll bar. It pops up throughout the program. It's not on all of the time, they reminded me, but it is on at different times, and it has all of our social media platforms, how to contact us, our phone-in number, all of that stuff. Please remember to like, subscribe, share, all of that kind of stuff. Our MediWeb app, it's a great app. Has tremendous utility for perfusionists, ECMO specialists, nurses at the bedside, advanced practice providers, APPs, formerly known as mid-levels. Has an IV rate and dose calculator in it. All of this has been validated. You can get it from the iTunes store or from the Google Play Store. Our podcast, whatever your favorite podcast platform is, you can listen to us if you're driving in the car and learn some stuff. You can even call in while you're driving in the car, whatever you'd like to do. So any podcast streaming software, type in PerfWeb, you'll find us. Next on the list is our ECMO course. We just did now get it approved for Category 1 CEU through the ABCP. The full course is accredited for 40 CEU, and the didactic only is for 20 if you are a member of PerfWeb and Perfusion Education and have an unlimited subscription, then this is included in your unlimited subscription. The didactic portion of it. The full course requires travel here to Houston, and you can register for that by going to the MediWeb site, clicking on Adult ECMO Specialist Training Course, and learn all about it from there. But it's an excellent course. I highly recommend it. It's not only approved for Category 1 CEU for perfusionists, but for nurses, CE credits, and for AMA, PRA Category 1 CME for physicians. And one of our faculty in that ECMO course is none other than Dr. Patel. And go ahead and throw it to him if you could. Dr. Patel is an assistant professor of surgery, Division of Cardiothoracic Surgery, Baylor College of Medicine. He is a cardiac surgeon that I get the opportunity to work with. He is a tremendous educator, a wonderful surgeon, does really good work, really cares about his patients, and is very patient, which is an uncharacteristic thing for most heart surgeons. And I've always enjoyed learning from him, just a really super good guy. And he's going to teach us today a lot of things about imaging that maybe we as perfusionists just don't really think about, but could help us tremendously in recognizing things going on and being a stronger participant in the overall care of the cardiac surgery patients, especially with ECMO and line placement, cannula placement, how the heart may be doing or not doing, et cetera, if the ARDS is resolving. All of these things are very important that I think we should know. Dr. Patel, thank you so much for being here. It's wonderful to see you again. The floor is yours, sir.
All right, Joe. Thank you. That was a very kind introduction. And very generous too. Thank you for the opportunity for having me here. I'm excited to talk to everyone about imaging. So we've got some very good practical examples of things I've seen in everyday practice, and the way I look at imaging is it's a great resource, and it's almost liberating to know it very well, because then you're less reliant on other people for interpretation, and it can really help you when you're in a jam, especially when you're at a smaller practice and you might have some limited resources. So I've kept this as practical as possible, and we've got some good questions and examples that I'll try to ask the audience about. So feel free to chime in when we get to those about what you think the diagnosis is, and if you have any questions related to that. These are the objectives. So we're going to review some basic principles about imaging and interpretation first, and some things that everyone I think needs to know. And then second, we're going to systematically review X-rays, ultrasounds, and CT scans. So this is a lot of information, and so this is not meant to be comprehensive on each thing, but I've tried to make it very in-depth on X-rays and even CT scans. And we'll have some good examples, and hopefully this will be fun. So imaging principles. So we'll get started. So in my opinion, the way I was taught, imaging must be ordered with a purpose. So you have to have a justification on how it's going to change patient management. And so there's a tendency in modern medicine right now to order things kind of as a shotgun approach. And so we try not to order it just because. We've got to be answering a clinical question. And then in that same vein, if you order it, you've got to be able to interpret it. And so yes, we have radiologists who are quite helpful, but I think we've all experienced where if you're in the middle of the night by yourself, you need to be able to interpret that on your own. You can always call for help, but you should be more independent than not, in my opinion. And so even if it's just with basic X-rays, and as far as ordering imaging studies, the mantra is start from non-invasive to invasive. So you always go for the simpler studies first, the ones that have the least side effects. So non-invasive means that would include things like X-rays and ultrasound. So things where where you don't even need to transport the patient most of the time, and you can do it at the bedside yourself. So, more invasive studies are, of course, studies that require contrast, IV access, CT scans, MRI, nuclear medicine studies, and so some of those studies require the patient to be away from the bedside for several hours. So I consider these to be more invasive, and there's also contrast allergies that you have to take into account. So these are not benign, is my point, and we're going to talk more about that later on. But of course, CTs with contrast may also be contraindicated in renal failure, depending on severity. There's lots of considerations, is my point. And things like TEEs require sedation. And so even those are not benign. There's a risk of aspiration, cardiac arrest. These are all things that have happened before, and you'll definitely see them. So start with the most basic studies that you can first. So we're going to go right into X-rays first, and so I think if I could have anyone take something away from this lecture, it would be how to interpret basic X-rays, and so we've got some good examples of this. So on the left is a very simple X-ray machine diagram. So this is called a posterior anterior or PA X-ray. This is where the radiologists, technicians have the patient stand. The X-ray beams goes from the back to the front, and the X-ray plate is in the front. So that's why they call it a PA X-ray. Because the X-ray direction is posterior to anterior. So in the outpatient setting, that's the most common, gives a very clear picture, and so that's how many X-rays are done. And so at the bedside, what we're used to in cardiac surgery and on the perfusion side is called an AP X-ray, or anterior posterior. So the plate is on the back of the patient, and the X-ray beam travels from the front to the back. So why do we care? Why is that important? So in the AP image, so that's it's less sophisticated, and the imaging is actually magnified. So the cardiac silhouette is more often than not magnified. So that's why the heart always looks bigger on an AP X-ray than it does in real life. It has to do with how the X-ray is taken. And so that's why when you read the radiology reports for all those X-rays, it's always for especially surgery patients, it always reads cardiac silhouette is enlarged, and so but there's a reason. It's just how the image is taken. So you have to understand there are better ways to image other than an AP X-ray. So it gives us limited information. So what do all the colors on the X-ray mean? So some of this actually parallels CT scans. So in a way, it is kind of universal. So in accordance with the density, that's how the color appears. So things that are less dense, such as air in the lungs, is going to appear black. And things that are the most dense, such as bone, metal, artificial devices, are going to appear white. And everything else in between is a shade of gray. And so fat, muscle, soft tissues are all going to appear different shades of gray. And I think the CT scans are pretty much similar on that account. So CTs are essentially just a series of very fine X-rays that are done in slices, so when we're all taught to read X-rays, there's the most basic principle is that you have to be systematic. It's easy to get lost on the million things that are on an X-ray on any given patient. So you want to approach it in a systematic way so you don't miss anything. So so this is perhaps the most common way that's been described is ABCDE. So you start with A, which is the airways, you look at the trachea, the right and left mainstem bronchus. B, bones. You look at the ribs, the clavicles for any fractures. And C, cardiac silhouette. You look at if the heart is enlarged, if there's suspicion for pericardial effusion. You may not be able to tell that on an X-ray, but you can have an idea that the silhouette is enlarged. And sometimes you can even tell if it's the right heart or the left heart based on the appearance of the X-ray. So. And then D is for diaphragms. You want to look at seeing if there's any elevation in the hemidiaphragm, any free air underneath those as well. And then E is everything else, like anything else that we might not have covered. And then F, lung field. So you want to look at infiltrates, pulmonary edema, pleural effusions. And so those are probably the most common reasons that we do X-rays. But if you approach it in a systematic way, especially when you're first learning them, then it starts to become second nature. So, it's almost like when they teach us to think about ICU patients by systems-based approach. You do it at the beginning, and then eventually by the end of it, you're so used to it, it's like second nature. You don't even think. You just analyze those things stepwise. So let's take a look at a normal X-ray, and so there's a lot that we can interpret, and so let's start with. Let me see if I can point to this on the screen here. Just bear with me here for a second. So first, you can see the trachea, and it bifurcates into this is the right mainstem bronchus, the left mainstem bronchus, the carina. Sometimes that can be difficult to see based on the X-ray. So that's we can use that to confirm our ET tube placement. You can see the clavicle is right here. So an ET tube should be between the carina and the heads of the clavicle. Generally, if it's higher than the clavicles, it means it's at risk of coming out actually. So so that's the airway, and then B, that's bone. We talked about the clavicle. This structure, number one, is called a cervical rib. That's not present in most patients, but anyway, that's there. And so you can look at all of these ribs. They're not. There's no evidence of fracture or anything. And then C, cardiac silhouette. So this is the left heart border right over here, and the right heart border on the other side. So you can tell this is a normal heart, not enlarged. And so those are some of the basic things. Now, other cardiovascular structures. So this is the aortic knob. This is actually quite important sometimes. And so it's very subtle, but it can help you make some diagnoses later on. So it's often disrupted after cardiac surgery, not because we're doing much work there, but it's because the pericardium is open, so that always gets obscured. So, and you can also tell the outline of the left pulmonary artery and the branches and the right pulmonary artery, and you'll see those engorged in patients that are in heart failure. So, and so the radiologist will read prominent pulmonary vasculature or pulmonary vascular congestion, and so that's what they're looking at actually, and so. So I think those are important. And then other things to point out. So this is the costophrenic angle. That's what the CPA is called. So pleural effusions will start there. And so you'll start to see that fill up. This is, of course, the right hemidiaphragm over here and the left hemidiaphragm on this side. So, and then this BS is referring to it's just referring to the shadow from the breast. So you have to be able to differentiate all of those things. And one other important thing that's not shown well here is the border of the scapula. Sometimes that can actually be in the way over here, and that can be misleading for some other things. So I think those are basic things to look out for when you, and it's important to look at a lot of normal X-rays as well. That way you learn how to find abnormal. So, and Okay, so examples. So this is where we can kind of interact a little bit. And I left out the diagnosis, but if you guys have a suspicion, of course, this is an X-ray, so we can only go based on what we suspect. So anyone want to answer? What do they think is wrong here?
Let's see. Okay, let's wait and see if anybody pops anything up. Let me see. I'm gonna make a guess.
Don't let me tell you all the answers. So.
Okay, anybody guess? Do they get a prize?
Um,
Because that always incentivizes people to guess.
we get points, and there's some hard ones
You
in
get
here
points,
too.
there's
So we
some
can.
hard ones?
There's definitely some bonus points for some of the harder ones.
Okay. I'm going to say that is an acute aortic dissection.
Yeah, I think you're right. It's it could be dissection or just a very large aneurysm. This is a very prominent aortic knob, so something is wrong. You can't tell if it's dissection or aneurysmal, but it looks like it would at least be involving the aortic arch, even if it's this high up. So, and the descending aorta is not that big, at least based on this X-ray. So, yeah, something is wrong up there, and it doesn't look like they've had cardiac surgery. So, I don't think it can be due to other causes. So that would definitely require a CT of the chest.
Okay.
No.
Okay.
Any questions about that?
So do I get a prize?
Well, you get 1 point. Okay,
1
and
point.
we'll
Okay,
add them up towards
I
the
got
end.
1 point. Okay,
Okay.
come on, everybody.
Okay, all
next.
right. All right, and so these are two examples of similar things.
Ooh.
What do you guys think here? Reason I pointed it out is not everything looks the same every time, right? It's based on technique, and you can also. Well, this is a good example to point out. The X-ray on this side is wider than the X-ray on that side, and that's just because it's called overpenetration. It just has to do with the radiology technician how they shoot the film. So. Anyway, as an aside, the way you correct for that is you manually adjust the brightness and the contrast on your own because it can be confusing, and that's how you really compare the previous day's X-ray to today's X-ray. 'Cause you
Okay,
have to-
anybody online want to make a guess on this?
This one's an easy one. So,
It is?
yeah.
Okay.
Everyone
Well,
should know, or at least
Okay.
have. It's a.
I'm going to say it's a massive pericardial effusion.
Yeah, that's exactly right. So,
So I
yeah.
guessed right. That's 2 points.
It's 2 points.
I
2
got
points.
2 points.
So, yeah, you can tell the heart borders are definitely enlarged, on both sides. You
doing
can
pretty
tell.
good.
This one looks like it's almost a circumferential
what it
one.
was?
And because you can tell even the right-sided
Oh, you
border
did?
of the pericardium is enlarged as well as the left. So yeah, this looks like more of a circumferential pericardial effusion. Could be massive cardiomegaly too, but there's definitely some sort of an effusion there. And the reason I put this other picture here is to highlight. You can tell the effusion is more prominent on this side, on the left side of the heart, if you will, and the right side is more common. So this is actually more of a left-sided and posterior effusion. It appears this way because it's all in this one area here, and so that and this patient has had cardiac surgery. So this could be typical of an X-ray that you see of an effusion that's accumulating on the backside of the heart. So anyway, it's good to know, and especially comparing with the previous day's film will give you some insight on what's going on. So, okay, any questions on that? Okay, this I think is fairly obvious. So I put some easy ones at the beginning. So but there are different diagnoses for the left and the right. So
Okay. So, anybody? Let's see. We've
it's
got
got arrows
a lot
all
of,
over it. So this one's
We
not
have
that
a
bad.
lot of people. Nobody wants to guess. No, come on, everybody should get this one.
Yeah.
Even I got this one.
All right.
Well,
Okay, so-
go through
Go
your
ahead,
go
go
through it. Go through it.
Go. Okay. So you can tell on this image, that you can see the heart, the lung border is right here. That's this fine line over here, and you can see that there's more black color here, and of course on the side. So and up here at the top might also be a clue. Almost looks like a circular type of thing up there. So, okay. Any guesses, Joe, or should I give it away? It doesn't seem like.
Well, you wrote it down.
I did.
That's a pneumo.
Pneumo, yeah,
And
definitely.
this one's
Obviously a
tension pneumo
pneumothorax
over
and
here.
not that big on this side. You know, you can tell that, it's just accumulating that much space. It's not pushing the heart over, so that's important because, immediately looking at this, I'd be able to tell, okay, the patient might be mildly symptomatic on some oxygen, but not hypotensive from this amount of air in there. You know, that's probably about 25%, maybe even 30% of the hemithorax on that side. So pretty good amount. Needs a chest tube for sure. And so, by the way, I didn't show it on these pictures, but in case anyone has ever wondered, whenever there's an apical pneumothorax at the top, how much is too much? For when you need to intervene. It depends who you ask, but probably most of us agree if there's an apical pneumo bigger than 3 centimeters or so, you should do something about it. So that's when approximately 15 to 20% of the hemithorax is filled with air. So that's when we generally consider that to be significant. Less than that, you can probably watch it. So and so this one, it's a pneumothorax, but obviously a tension pneumothorax. You can see how it's pushing the heart over on that side, and so this could have been from attempted central line. It doesn't seem like it's from trauma, but it certainly could have been if the patient had a gunshot wound to the chest or something. Although generally they would have a small hemothorax on this side as well. But this patient needs an emergent chest tube. They're struggling and they're probably barely hanging on and hypotensive, and so just the positive pressure from the air is going to compress venous return and prevent that. So you can tell how quickly you need to see the patient just from the film. So, okay, this one, hopefully we don't see this one too often, but luckily there's arrows pointing there. So we can't really make it that much easier. But what do you guys think? What causes this?
It's air below the diaphragm.
We can't volunteer people, right?
I could. Jeffrey, Carly, Kelvin, somebody, Derek, somebody make a guess. Come on. No one wants to be wrong. I get it. I say it's, let's see, IDK this one. No, that's not the answer, Jeff. I'm going to say it's right heart failure with hepatic congestion.
That's a big guess. No, definitely not. And so
I
know you're
lose a
messing with
point?
me, Joe.
Do
but
I lose a
it's,
point?
you lose 2 points for that one, I think. And so this is the border of the hemidiaphragm here. That's that white translucent line. And so this is free air under the diaphragm. So that
You got it right.
The patient's got either a gastric or a bowel or colonic injury, and you can also see it on this side. So it's definitely real, and so you've got to do something surgical about that, and so from the abdomen at least. And this can be misleading, and it's not often recognized. So that's why I put this in here. It's usually not this obvious where you see a large space. Sometimes it's just a sliver, because you have to consider that when we get AP X-rays, patients are not fully standing up, right, or sitting up, so not all of the air will rise to the top, so to speak. So you might only see a little bit, and sometimes it's just on one side or the other side, and so you got to have a high clinical suspicion. But this is pretty classic. And the other thing to note is sometimes in some patients, not most of them, but probably 1% of the time or so, they'll have some air, and it'll look like the colon is here, higher than the liver. That can happen. That's actually a thing. I forget the actual name for that sign, but some people actually have the transverse colon be up this high, and so that's actually good to know. I have a patient like that right now in the hospital, and
Yeah, I got it wrong.
yeah, so yeah.
Because your pedicle's wide.
Okay, all right, and so this one's a two-parter. So it's got a part A and a part B. So, any takers?
Let's see. I'm waiting to see if anybody is going to answer, so I don't jump the gun. Okay.
I know to some it might seem basic, but we've tried to.
No, I think they're good.
We'll incrementally
They're fun.
teach some more things about it as well too. So.
I'm going to say that one's a hemothorax.
Yeah, hemothorax or large pleural effusion could be either one, and so without the background of what's going on with the patient, we don't know. And but yeah, that's a good amount of volume, more than half the chest, I would say, and you could see the heart's being pushed over to that side too, and you can tell that based on the airways as well. Even the trachea is shifted a little bit that way. So and there's the aortic knob. So the heart border is probably just till about right over there, and the rest of this is all fluid. So.
I think that was an X-ray. I think that X-ray is from New York, and it was somebody that was riding the subway that got stabbed.
Yeah, it could be. Yep, that definitely could be. And how much volume do you guys think this is?
2 liters.
2 liters. Vicky says 2 liters. I agree with her.
Good guess. I think that's true, and so I mean we always try to approximate based on films how much patients have, but you can have somewhat of an idea, and so each chest, each hemithorax, I mean, can hold a lot of fluid, up to 3 liters in a lot of patients, and so the fluid that's required just to blunt the costophrenic angle is probably only about 300 to 500 milliliters. So if you have an effusion with a small meniscus here, that's enough just to be about that much, honestly. So and that can be a sizable amount for some patients. They might be symptomatic from it, and so and when you start to this is just an approximation. This is based more just on practical experience rather than the radiologist. They'll never give you this kind of measurement, but I tend to think if it's about a third, it's going to be about a liter. If it's this much, I agree, about 2 liters. And if you can barely see any lung fields, any of the interstitial markings for the lungs, you're going to be about 2.5, 3 liters probably. So that can help you know what to expect, especially when you're planning a surgery or putting in a chest tube. So.
Yeah, you guys, and on bypass, I think this is a very important point, because if it's blood, then we want it back in the pump because we're struggling. If we lose 2 liters in the chest, it's not that hard to do.
Exactly.
But if it's diluted Kool-Aid, it really hurts us when you suck that into the pump. You really have to be aware of what is in there, and you can't tell until you start sucking.
That's right. Absolutely right. Yeah.
You stick the sucker in there and you see it's coming back and it's clear. Pull it out and go with the cell saver.
Yeah, exactly.
Because the cell saver sucks so fast.
Yeah.
But you put it in there and you see it coming back really dark, nice thick blood.
Yeah.
Probably what we want, but we've probably already told you about that.
Exactly, and most of the time it won't be just frankly bloody in those cases. I mean, I know we're going off on a tangent, but it's most likely going to be irrigation. It would be very rare. It would only be if the bulldog comes off the mammary or something like that, in which case it's legitimately blood. Most of the time it's mostly irrigation.
Yes, so, and we just do not like that.
Yeah, exactly. But each side can hold a lot of fluid, so. Okay. So this, if you guys haven't encountered this, you will in the middle of the night. This is one of those 2 a.m. scenarios. So you have a whiteout of the left chest, but what's the diagnosis? How do you know what's what? So, and I'll give you guys some options. Well, no, actually, I don't want to give it away. How do you know? There's 2 separate answers, I'll tell you that. And how do you know which one is which in the middle of the night? So,
well, I believe that's a hemothorax because it looks like on the left image that the trachea is deviated off to the right chest.
Okay.
So I believe that's a tension hemothorax.
Okay. Yeah, I agree with you there, and so there's definitely some fluid there. What about the other image on the right side? What causes that?
Mucus plug.
Sorry?
Could be a mucus plug.
Yeah, you're right. That's a mucus plug, and it's sometimes very hard to differentiate between these two. I've had this happen in the middle of the night. Very common scenario, and sometimes it can be a mixed picture, but there are some things that you can use to kind of know, and they are evident on this X-ray too. So the first thing, as Joe pointed out, on the image on the left, the heart and the trachea are shifted. So you see a mediastinal shift. So you know that there's some space-occupying lesion of some kind. And what I've outlined here, poorly probably, is the heart border. That's where I think the heart border would be. So it's clearly being pushed that way by something, and the easiest way to know that is that. And the other thing you can actually use when you compare it to the other film. So here you don't see the heart and the mediastinum being pushed as much, but you can also, if you look closely, you can tell the rib spaces are actually much wider when there is some fluid or some blood inside that chest. So that's how you know, and that looks pretty wide to me. And when you compare it to this side, this is where the lung would be atelectatic from a mucus plug. That's a very small space, especially when you compare it to these ribs on this side. So that's, definitely shrunken, and that's because the lung has collapsed, the heart's pushed over, and so that chest is just not inflating as well as it should. Remember, the chest wall is rigid, but as we breathe, it's supposed to be elastic, right? There's some elastic recoil from when we take a deep breath. So and you can tell that when the lung is collapsed, it's not going to do that. So the hemithorax kind of shrinks down a little bit. So so at sometimes in the middle of the night, I've been there, and there's patients that could have either one, and you have a badly rotated X-ray, so you can't really tell. So I've actually measured the rib spaces just to kind of get an idea, and so there are other things you can do too, but. And so the other thing you can do is use your clinical history. If that patient has been coughing, obviously, and is at high risk of aspiration, then you should suspect a mucus plug. If they've just had an intervention, then it's more likely to be blood or something else. So use what you have, and plus, bedside, use an ultrasound. This is what it would look like if there's an effusion on an ultrasound. You just stick the probe at about the level of the 7th intercostal space on either side. You can see the diaphragm moving and also the lung border. This is actually the lung parenchyma that's being squished down, and the black is the fluid. We're going to talk about ultrasounds later, but this just what I'm highlighting is that at the bedside you have a quick way of determining that without transporting the patient for a CT. So, but if they're stable, of course, go for a CT scan. And from a practical standpoint, from our patients who've undergone cardiac surgery, if they're on ECMO, have a lot of other stuff going on, what I often will do is I'll perform a bronchoscopy first, rule out any mucus plugging, and then repeat the X-ray to see if that's fixed it. So, and if that hasn't, then you know that it's more likely fluid. So that'll save some time, and so there's a lot of things you can do just at the bedside to get yourself out of trouble, especially when you're by yourself. So just with plain films and ultrasound, you could have made that diagnosis, really. So, and okay, these are some other examples. Same diagnosis. This one's not meant to be tricky. So,
Do you need us to guess each one?
no. I think
No.
just all of them. Yeah,
There-
just one diagnosis.
So there's one diagnosis?
Yeah.
Okay.
Aspiration.
Hmm?
It's aspiration.
Aspiration pneumonia?
Yeah. Pneumonia of any kind. I think that's the most likely answer. Infiltrate, I guess, if we're being very, proper in the way as if a radiologist would describe it. Yeah, it's an infiltrate, most likely pneumonia. So this is on the right side of the lung, obviously, the right upper lobe, and so this is more in the right lower, or right middle lobe, actually, and so
Jeff Campbell guessed pneumonia.
okay, good.
It came
Jeff.
late, but he got Jeff. Good
Okay,
job.
Jeff gets a point, and then you can tell this is the left lower lobe, and so they tend to follow the distribution of the lobes, but not always. Sometimes it is actually hard to tell. I would say more often than not, it's not going to be like a perfect line like this has illustrated over here. It's going to be more like you see some junkiness in one of the lobes and you're suspecting it. That's probably the most common presentation. So it won't be as clear as this, but this sort of gives you an idea that there's some infiltrate from a cause. Could be aspiration, could be community or hospital-acquired pneumonia, ventilator-associated pneumonia, could be any of those things. So, and okay, all right. This is another one. So, not pneumonia. Probably this picture on this side would be more indicative of it. So, and I guess this, without the clinical context, it could be more than one answer for this one. So,
Okay, so see if anybody's going to guess before I do. So let's give everybody a da da da. Do we have that music? Da 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 da. Da 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 da. Okay, I'm gonna say it's onset of ARDS.
I knew you were going to say that. It's ARDS, pulmonary edema, could be either one. Both look very similar, but you can tell especially on this X-ray. Yes, there's almost ground glass opacities, or pulmonary edema throughout both of the lung fields, and so they're very obvious that there's something like that going on. And on this side, I put this in here just to highlight the fact that sometimes it's not perfectly symmetrical if it's pulmonary edema like this. Sometimes it can just be on one side, so it can be confusing because you might be suspecting pneumonia, and so it's not always that obvious. So it can be a little challenging, but whenever I see an X-ray like this, which is actually it's often in our heart patients, especially pre-op, then you want to question, okay. Or look at their history, examine them. Have they been diuresed? Do they have heart failure? Is that what's going on? Or have they been coughing and have a fever or a white count? That might be causing pneumonia. So you of course have to have the clinical context to put it together. But pulmonary edema can look just like that. So that happens often. Okay, all right. This is probably one of the hardest ones that I have on here, but it's an important one. And also a very practical example of something that you could see. So,
okay, I'm gonna call some folks out here. Okay, I want somebody, Derek, Kelvin, Carly, Chul, Jeremy, Ahmad, Jeffrey. I want all of you to guess what this is, if you can. Doesn't matter if you're wrong, because I'm gonna guess and probably be wrong too. I'm going to go back to one of my old standards. You know what it is? And it's a bonus point. I need it right now. No?
I mean, I would almost
Anybody
say.
online? Come on. You will win a PerfWeb cup. Right here.
there you go.
You'll even hear a goat scream. Come on. We got to do it. Okay. I'm going to say, all right, I'm going to guess. Nobody's guessing. I'm going to say it is, there's definitely pulmonary edema. I say it's, let's see, right pneumothorax is somebody's guess. That's Jeffrey. I don't think so. I think that was a good guess, but I don't think so. I think it's heart failure and pulmonary edema from heart failure. I think the heart looks very, very dilated. You got cardiomegaly. The right side looks really distended. The left side looks distended too, and I'm saying it's heart failure.
Yeah. So it's definitely heart failure. There's a more specific diagnosis, but we're going to take it a little slow. So yes, the heart is definitely big, and you can tell that both the left and right sides of the heart, especially the left side, is very big. So they're definitely in heart failure, and you've got some pulmonary edema. Even on the left side, you've got some, but most it seems like as if it's almost concentrated in this right side, especially the right upper lobe. And so which is interesting. It's not a pneumothorax because you can tell the lung markings are all the way throughout here. This is the diaphragm. You can tell the lung markings go all the way there, as well as the chest wall border and the apex. There's lung markings throughout. I'm sorry if it doesn't come across on the computer screens as clearly, but yeah. So that's why it's not a pneumothorax. So Joe is right. This is heart failure, pulmonary edema. There's one a specific etiology that causes this particular type of heart failure. This is a pretty classic type of X-ray, though, and so you would need an echo to confirm. But this is most often isolated right-sided pulmonary edema due to severe mitral valve regurgitation, and so this can look like that. And this used to be one of the most classically taught X-rays, I think. I think in cardiology, I've seen it at least once or twice in practice. So it is real. And so why does it occur this way? So it tends to happen. Like, why do we have more pulmonary edema on one side as opposed to the other? It has to do with the orientation of the mitral valve. And so anatomically, when the heart is sitting, the mitral valve is like this. That's what I'm trying to indicate with the blue oval. And the regurgitation is going to be that way. And so for whatever reason, the right superior pulmonary vein tends to see more of the congestion, and so that's why it happens more on the right side than the left side. And so anyway,
I didn't know that. I had never even imagined that was possible.
Yeah, it's definitely well described, and it's out there. And in fact, they call for this reason it's often mistaken as pneumonia, and so they call mitral valve regurgitation the great masquerader in some of the internal medicine text because of that. It can mimic other things. So it looks like pneumonia, but if you look closer, it's clearly cardiomegaly, some heart failure, and so that's the diagnosis. That one, to be fair, that is more of a guess what I'm thinking. Definitely a more harder question than the other ones, but it's you will see that actually.
Do I get a half a bonus point?
You get I'll give you more credit than that. You can get 2 for that one.
Okay.
That one is a legitimate heart one, but you got heart failure and pulmonary edema, and so. Okay, and so prosthetic devices. So this is just an example of just what some basic ones look like. We all know what a AICD or pacemaker looks like, hopefully. And by the way, if you guys aren't aware, they actually make apps now where you can pull up an X-ray and you can use your camera to identify what kind of device it is. Like if it's Boston Scientific or Medtronic, that way you know which rep to call.
Wow.
I think it's called Device Detector. It's helpful when the patient can't give you the history. And so you can know which person to call to, deactivate a device or whatever. So, and this is what an aortic valve ring looks like. That's how it's oriented. It tends to be kind of more closer to the midline, and you may not see the exact circle, if you will. A mitral valve, as we showed before, looks more like this. So that's how those valves are oriented. They're actually closer together in real life than the textbook indicates. They're right next to each other. So, and so. There's a famous saying that anatomists are optimists. They're not always as far apart as they look like in the textbook. So, and this is what a AtriCure clip looks like. This is a left atrial appendage occlusion device. These are very common, and so until you'll start to see these on more and more X-rays, it's becoming the standard of care that almost anyone that gets a sternotomy, especially for CABG, will receive this because this helps reduce the risk of stroke. And at least by 50%, and the patient may not need anticoagulation if they go into AFib. So that's the reason why we put those in. So and so we use it almost 100% of the time for our pump cases. So sternal wires, we all know what those look like. Okay. All right, and so now I think we're going to review some stuff about X-rays and ECMO, and then we'll take a break after that. So for what we do, it's daily routine X-rays can help verify cannula position and placement. Of course, you can use transthoracic echo TE to also confirm the same things. So I've got some good examples of some cannulations and just how you can use X-ray to verify things. And the reason this is important is you can't move the patient, and you want to make sure that things haven't been shifted, and that your intended therapy is actually working. Because if you have a malpositioned cannula, then there's no point in whatever it is you're trying to achieve.
It's so funny you bring that up because I just did a lecture yesterday, and catheter malposition in this one particular study was their highest cause of mortality.
Oh wow, yeah.
And I just sent Vicky another paper that I just read, where in that cannulation that you have up there now, the return cannula ended up invaginating into the access cannula, and they were just one big loop.
That's
and
impressive,
so
actually.
That is, and
I've
it
never
happened,
seen that, yeah.
and it happened apparently, according to the study, which was done at a big hospital down in Australia, the Alfred, which is a big recognized hospital, that does a lot of ECMO center. And it happened after rolling or after turning, repositioning the patient.
Wow.
is when it occurred.
Yeah. And those are the type of things that you cannot rely on a radiologist to pick that kind of stuff up. That's based on practical knowledge and looking at several x-rays of everyone who's cannulated every day. So that's just pattern recognition, and that's the purpose of doing this is to the more of these you look at and the more questions you ask, what's this, what's that, and you ask someone for help. That's how you pick up on these things, because it's I'm sure everyone is from different parts of the world, but our most common radiologic interpretation is support lines are stable, lung fields are unchanged. That doesn't help us make any decisions. So you've got to look at it yourself, and so that's my whole point with this. So we'll look at some ECMO configurations. So this is an example of femoral VV ECMO. So you have a access cannula or drainage cannula in the IVC, that's highlighted here, and you have a return cannula or reinfusion cannula that's supposed to sit with the tip at the right atrium. So X-ray can be very helpful for this because you want to make sure that this cannula sits not too low, because otherwise you'll get hepatic venous congestion. So you want it to be right at the cavoatrial junction, and so I'm sure it might be a little hard to illustrate here, but you want it to be right about here, almost at the border of the diaphragm. And your return cannula, that's this large cannula that you can see here, the tip is right here in perfect position at the cavoatrial junction where the SVC and right atrium meet. So the distance in between the two to prevent recirculation should be about 15 centimeters. So you can check this every day to make sure that your cannulas haven't shifted down or up, especially the groin cannulas. That way you ensure that you're in the right place and that nothing has happened. And sometimes these cannulas can even migrate into the right atrium, right ventricle. So you have to, rarely, but it can happen. So that's why it's important to look at this, and also to look out for the fact that if the distance is too close to each other, you might have some reperfusion phenomenon. That means where the blood recirculates within the circuit and the patient isn't benefiting from that oxygenated blood. So and in this case, probably X-ray is even more important. This is femoral VV ECMO, where you have two large multi-stage cannula that are positioned in the femoral veins, and ideally you would want to stagger them out just like you would have over here, and so where you have the reinfusion cannula as close as you can to the right atrium, and your drainage cannula lower. So so with this strategy, it's harder to stagger those out, but because everything is from the femoral veins. But it's even more important to look at the films for this one to ensure that you have as much distance as you can between the two. So so anyway, I actually think on the X-ray the cannula tips are too close together in this case, so I probably need to be separated out a little bit more.
Put that NG tube to suction, man.
Yeah, and that NG tube isn't working. So this is what happens when you look at too many X-rays and you know that NG tube needs to be flushed or put on suction.
Something is wrong.
So that's a good point, Vicky. Yeah. And so this is a crescent VV ECMO cannula. This is a dual lumen single cannula. This is probably the newest one, preferred at many places now. We use this one the most often for VV cases, and so an X-ray and fluoroscopy is invaluable in these cases, because now they've actually put radiographic markers on the cannulas, and so you can see the dots over here, and then down here as well. So and so these dots at the top are indicating the hole for the drainage port of the SVC, and number 3 below these 3 dots here, these are the drainage ports for the IVC. So blood goes to the ECMO circuit and it re-injects at number 2, indicated by these 2 dots. So this is important because these 2 dots are opposite the side hole, which is supposed to be pointed towards the tricuspid valve. So this is probably the most important part of that diagram, is so when you have those 2 dots oriented away, it's opposite the opening on the ECMO cannula. And so that way you're directing blood flow down the appropriate pathway. So anyway, and it might be hard to actually see that on a bedside X-ray, but you can at least confirm that the drainage ports are not too far in and that the cannula hasn't migrated. You may not be able to see those tiny 2 dots without fluora, but you might be able to, depending on how good your X-ray technician is. So, but regardless, it's something you'd want to check for every day. So. And in this case, it's showing the ECMO cannula in the IJ. We typically like it in the left subclavian vein, and so just because it sits away from the neck, it's less positional. And so this is an example of that type of cannulation, where they've gone into the subclavian vein, and you can see that this is actually a small patient. Might even be I don't think they're a pediatric patient, but they are pretty small. So you can tell the this SVC port and the IVC port are very far apart, in the tricuspid valve port, or the re-injection port is right over here. So the cannula is huge compared to the patient, actually, but that's what I was mentioning. It's probably just a smaller size patient. So
That looks like an elderly female to me.
yeah, just small. Yeah. Okay, another reason for practical purposes, you might want to have some good plain films. So all of these other devices that we place in patients, you can use X-rays to confirm appropriate placement. These are the things that I look at every morning when we pull up the 5 or 10 X-rays that we need to. So so often with ECMO we have venting techniques, and that can be even just using inotropes to allow the heart to eject. It can be a balloon pump. It can be an impella. But I actually didn't illustrate balloon pumps, but I probably should have. That one's easier to look up. But an impella position can be confirmed on a daily X-ray as well as echo. So this picture shows a very well placed impella in the left ventricle. So this is coming from the femoral vein, curving around the aortic arch, and so that's the motor housing over here, and then you have a curved cannula with the tip over here. So this tip is typically about 3.5 or 4 centimeters from the aortic valve, which is sitting right about here typically. So so anyway, so you can confirm that this on X-rays that this is the appropriate curve. That's how it should look. Should be pointing towards the apex of the heart, and the aortic valve typically sits about right here. So this is in a good position, satisfactory, and so it can help you make sure that you're at least in a good place. For more sophisticated, positioning, you can of course use echo. In this picture, what I'm trying to illustrate is that this is too far up. This pump is in the aorta, and so you can tell the motor housing is in the aortic arch, and so this is clearly malpositioned. It's not even in the heart, and so the aortic valve is probably here. So this has come out. And so this is probably going to have great flow because it's in the aorta, and it might not set off any alarms. So, but it's not helping vent the patient. So probably needs to come out, honestly. And the heart doesn't look too big, so probably not benefiting the patient. And this happens, quite often, especially when we have other professionals that we help with who place these. So, and so same with this. And so this one. You can tell just by the angle that it's not placed. It's not pointing towards the apex. This one's probably tangled up in the mitral valve cords or somewhere, or it's somehow abutting the side wall of the left ventricle, not pointing that way. So this one often would give you suction alarms and some other events and things like that. So it should look like the first picture that we're trying to indicate. Should be that nice L-shaped curve, and so. And sometimes we might be able to salvage this and put it in the right position using echo. So, okay, all right. So I think we've got some examples, and then we're going to take a break. We've got about 4 or 5 examples. Okay, all right. And okay, first one. This one is straightforward. The next ones are all not so straightforward. So, okay.
We'll see if anybody's going to guess online. See, I'll guess. My guess is left-sided hemothorax.
Yeah, left-sided hemothorax or pleural effusion. We don't know, and it could be either one. But yeah, definitely large fluid collection. Pretty straightforward, right? And so that part we can tell. And again, this one's maybe 2 liters and maybe 2.5 even. So, okay, all right, this one. Anyone in the audience?
I'm waiting to see. Let's see. Okay. Okay, I think I know. Let's see if anybody's going to guess. I like guessing. I have fun. I'm going to say that let's see, nobody's guessing. I'm going to say the ET tube is in the right main stem.
Yep, absolutely. So this could easily be fixed as soon as you see this at the bedside. Yep, this is the carina right over here. You can tell this is the left main stem bronchus going over here. So yeah, this is clearly right main stemmed, and so should be just slightly higher than that. So this patient probably does have a shorter trachea too, but should be between the carina and the clavicle. So it just needs to be probably right about here. So it just needs to be back down a couple of centimeters. So.
Jeff Campbell says cardiomegaly. I mean,
yeah. I mean, they do have a swan in. They've got some heart failure for sure.
Yeah.
And so, yeah. And
okay.
so, yeah.
So Jeff gets a half a point.
Yeah.
Okay.
This was a good one.
Okay.
Someone will definitely see this in the audience.
Huh. Okay. Let's see. Right. Okay. I think I know. Let's see if somebody's. Haha. Good thing I'm not ready. Me too, Jeff. Me too. Okay. Okay. Because now the pressure's on. Okay. I'm gonna have to answer this and guess. All right. I'm gonna say it is pulmonary edema on the right side. Well, there's just pulmonary edema, but a left-sided pneumothorax.
Actually, and it may be hard to translate on the pictures, but no pneumothorax. There are lung markings that go all the way to the edges here, and so hopefully you guys can see that clearly as well. But no pneumothorax. There is some pulmonary edema. To be honest, I actually can't tell exactly why they have so much here, but there is one more very important thing, and that's the most important thing, actually.
Okay. Oh shoot. Okay, hold on. Don't be rushing us.
Okay, I won't rush. I won't rush because this is important.
Oh Lord, do you know what it is?
That central line doesn't look right. That's what that is.
Yeah, that central line does look jacked up. I agree with that.
Vicky's right.
We're in the right place?
Yeah, Vicky's right. Yeah.
Okay. So all right, well, what is it?
Yeah, the central line is in the aorta, and
so
they
the
tried
central line is in the aorta.
So
come on, that's not. I mean, that's a trick. Okay.
Not really. No. It should be right over here. It's when it crosses the midline. It's most often in the aorta. In fact, you can almost kind of tell. So they probably went through the carotid artery here, but it's sitting in the aortic arch right over here. This is the outline of the axillary artery, and the carotid artery here, subclavian artery would be that way. So this is the innominate artery, and the arch somewhere right over here. It should not cross the midline, is my point. Central line should be on the same side if it's a right IJ. So that one is helpful to know. So, and most important thing to do is not to panic. This looks like a 7 French, so it should be able to come out with some good pressure using one finger, not a fist at the bedside.
Jeffrey said Jesus.
And so it can happen. And so I'll tell you a story about I had something similar. It's even a little more tricky than this, and I thought it was a line in the aorta, and it wasn't. So on the left side, and this is one of those, of course, less than 1% of the time people have this anatomic abnormality. If you're placing a left-sided IJ central line, so it should go through the innominate vein, that one does cross the midline, right? And it should end up right over here. So for the left side, it's supposed to cross the midline, but the right side, this is not right. That's clearly in the wrong position. But the story I was referring to is the central line that I placed from the left side went straight down here. And I thought, oh man, am I in the descending thoracic aorta? Like it just, and it could be. But I went back, I ultrasounded myself, I checked again, and I saw an old CT scan that the patient had. They actually had a persistent left SVC. So the central line was appropriately placed. But if someone has a left SVC, it'll be all on this side, on the left side. And so it's you guys should Google the picture of what that looks like, because it might happen. Happened to me once, and I thought it was abnormal. And the funny thing was, in that patient, they got better. We took the line out. Someone else placed the line 2 weeks later in the same spot and freaked out thinking the same thing. And but then I told him, no. Remember, that patient has a persistent left SVC. It's fine. It's, so. Okay, this one, we haven't talked about this one as much, but
Okay.
Yep. I see it.
actually, I don't know why this patient has this diagnosis, actually, but it's kind of interesting.
Well, looks like a fractured rib.
Yeah.
With sub-Q.
Yeah. At some point, they've had a sternotomy, but for whatever reason, you've got fractured ribs, at least two, and you've got what's all this called?
Sub-Q.
Subcutaneous emphysema.
Yeah, subcutaneous emphysema, right? This should not be. You should not see air within the gray parts of the soft tissue in the neck and the lateral chest wall. So this patient has subcutaneous emphysema related to probably minor lung injury from these rib fractures. So, and there's no pneumothorax. That's actually the most important thing. You can see lung markings throughout. So, so anyway.
Aggressive CPR.
What's all that
It
prominence
could be,
around
yeah.
his
Although
neck?
you generally see rib fractures more in the midline, so it almost looks like this patient fell.
What's
That's
this
about-
up by his neck?
Say again.
By the neck. I can't really tell. There is some subcutaneous emphysema there too, but I can't really get a good outline of what's
Some
going
weird
on
markings.
there. Yeah. That you're right. That doesn't look completely normal there. So
Like fishbone kind of look.
yeah. Okay, this is not a good day if you have this.
Oh, I know what that is. Everybody knows what that is.
Yeah.
Anybody know? Let's see. Everybody's got to get this one. I know what that is.
Give you a hint. They have had recent surgery. These are staples, by the way. That you can tell all along. They've had a pretty big left thoracotomy. It looks like.
So I'll ask was the count correct? That's what I want to know. Was the count correct?
It's always correct.
The count was correct. Somebody doesn't know how to count. I see that ribbon.
Yeah, so there's a retained foreign object. This is the radiographic marker from a lap sponge from the operating room. So and it doesn't look like this is an open chest, so they left that in there. So they have to go back and get that
one
out.
radiologist called it placement of a new drain.
Placement of a new drain. It's a new drain.
So to be honest, not the radiologists might not call that. They might actually say, oh, some radio opaque. Whatever thing, it might not be actually called that, but you should be able to recognize that. And the one for a Raytech, which is a 4x4 sponge, is different. That one has more. It's just a different radio opaque pattern. But anyway, good for you to know if you ever see that. So
No, we had that over there, and the radiologist called it placement of a new drain.
Yes.
placement of a new drain.
That's what they put on the report.
I actually saw
like, well,
this
that was
on
nice
an
of
X-ray
'em.
after an esophagectomy, and so it was a esophagectomy. So that in that surgery we do a laparotomy, create the gastric conduit, and we're on the right side of the chest. So we're in two surgical fields, and I saw this marker right here.
Oh.
Right in the middle, and I was thinking to myself, "Wait a minute! Like I felt around, I didn't see anything, and I looked at the X-ray 3 times. I mean, it looked just like that. Then I went to go examine the patient, and sure enough, below the patient in the sheets that they used to pull the patient, there was a lap or a towel with that marker. So it wasn't actually in the patient, and so it was just below. But when they take the X-ray, it looks like it is. So don't be fooled. It's not a substitute for physical exam at the end of the day. So
Well, let me tell you this. Let me tell you this story if I can. Let me tell you the story. I think everyone will get a kick out of this. This is back in the days when we could do this. So, hey, Dave, we're gonna have a short conversation anyway. So, you can't have him and us at the same time. Yeah, that's beautiful. I love that, dude. You're so technologically advanced. Thank you. So, we had done a case. We were hanging out, and we heard this scuttlebutt going around, and the competitive surgeon in this particular hospital I used to work didn't get along with too many people. His first assistant said, "You left a bulldog on the circ." And he argued and argued and argued. The count was even incorrect, and they still argued.
Right.
And they closed the patient, sent him to the ICU.
Yeah.
Patient decompensated eventually, didn't do well. they sure enough X-ray. They found saw the bulldog, had to go back, get the bulldog off the graft. It had clotted off. It was all kinds of drama. Okay, all kinds of bad things happened. And the surgeon that I was working with at the time, he was, it was terrible. We're laughing. Poor patient suffering, but we were laughing. So I don't know. About a month went by, and this is back in the old days. Okay, so you can get away with this kind of stuff. And I got 2 clips, 2 bulldogs, and I told the X-ray person, I said, "Look, I need you to take 2 X-rays," and I put the bulldogs on the chest, took 1 X-ray, then took them off and took the other X-ray. And it was back when they would take the X-ray film and put it up on the viewer and then let the guy know, hey, your X-ray's up. And I watched him get up and walk back there, and he came back and he sat down, and I could just see the blood had rushed out of his face. He was white as a ghost, and he just looked really pained. And I was like, what's going on?
Right.
And he goes, come look. And I went back there and I looked and I said, oh, wait a minute. And I pulled that one down, and the guy had given me the other one. I said, this is the real one. That dude never forgave me for that. He never forgave me, but it was the best day of my life because I really had him good.
I would be pretty upset after that, though, too. But he should have listened to his staff if the count was incorrect, though. That's we've all heard stories about. You're only as good as everyone helping you. So
but they got to get the count right.
They do have to get the count right. Yeah.
Got to do that too.
And most often, when they look at retained foreign objects, the count is always right. So
yes.
It's it's at
That
least
doesn't
reported.
make any sense. Exactly.
No. All right, we'll take a quick break, and then we'll do the rest.
All right. So how about if we do that 5-minute break? Okay. We'll get that.
Okay, all right, welcome back. So we're going to move away from X-rays onto some other things. So ultrasound, echo, and then CT scans. So it's hard to really cover all of these in depth. You know, I wanted to spend more time on X-ray. So in this second half, we're just going to highlight how these are useful from a practical standpoint, and I'm just going to highlight some of the basic principles that you should know. So ultrasound, it's becoming an invaluable tool now. It's easy, non-invasive. There's no radiation. And really, it can be self-taught. And depending on what your practice is, if you have the ability to learn it, I would encourage you to utilize it as much as you can, because it just doesn't. There's no risk on doing it for patients, really. So, and anyway, especially if you're doing anything procedural. I mean, we have. I think there's an increasing use of it, even with surgeons, and so breast surgeons are learning how to do it on their own. ENT surgeons who do thyroid surgery even take a look at these on their own. But of course, cardiovascular, for access purposes, and for looking at the heart, it's an invaluable tool. So, and they're getting even smaller and smaller. So.
And that has been, that is now the standard of care, right? Because I mean, I remember back in the days, you would stick and pull back and stick and pull back, stick and pull back, and hit the vein, and then move over and hit the artery, go through it, come back.
Right.
You know, it was stick. Now it's pretty much any line placement is really intended to be done, or standard of care is with ultrasound.
Yeah, I mean, if the patient is stable, has a pulse, you should try to use it. It'll increase your success rate to use the ultrasound. I mean, if you're undergoing CPR, okay, you can't. You just have to put some lines in and accept that there might be some risk. But it really reduces hematomas, issues, and I'll highlight a little bit of that later as well. So, ultrasound is based on ultrasound waves, sound waves that are transmitted to the object, and they return to the transducer, and an image is created on the screen. And so there's no radiation from this. And so based on the attenuation or the density of the object, you get various shades of gray, white, or black. And so things that have decreased signal are air, bone, and gallstone. Those appear more black on an ultrasound, and soft tissues are more gray. So and so that's really, there's not many things that are white, I suppose, on an ultrasound, but it's mostly black and gray. That's what it ends up being. So, and the black just highlights the point at which the ultrasound waves don't come back. That's why it appears that way. So, these are just some examples of some terminology that the radiologists use. So, anechoic means lack of echogenicity. So that would be when something is black. So that's when there's fluid, such as the bladder, blood vessels. So those appear black. And so things that are hypoechoic compared to the surrounding structures, that means they're taking up less light on the ultrasound picture. So that's what they're trying to illustrate on this picture here, that the liver is more dark gray compared to the right kidney. And that could be because it's being perfused less. So that's why something like that would be important, is if something is hypoechoic, that's generally what that indicates. So, and then in that same way of thinking, hyperechoic means something is brighter. So the right kidney is hyperechoic compared to the liver. So isoechoic means the same. So, but really the most important things I think to know are anechoic, hypoechoic, hyperechoic. So just so you understand what they're talking about when they give you the report. So, and when you use a color Doppler for the ultrasound probe, first thing, make sure that you have the probe marker pointed in the right direction. Otherwise, you confuse left and right for right to left. That happens very commonly, actually. Even in some people who have been trained how to use the ultrasound. So don't be fooled by that. So I always check with my own finger that left corresponds to left on the screen. Otherwise, you'll be backwards. So, and when you use Doppler, so Doppler is a feature on ultrasound machines that allows you to get flow for blood vessels. So, and they use red and blue to indicate the direction of flow relative to the probe. So that's an acronym for that. So blue means the blood is going away from you, and red means it's coming towards you, meaning towards the probe. So you can tell the directionality of the flow, i.e. artery or vein, based on how the color looks. So, and so. Okay, and then this is what Joe and I were talking about. It's become the standard of care for access for central lines, arterial lines, and the reason I think this is important is it's much safer as far as avoiding injury to surrounding structures. So let me give you an example. So when this picture on the right, this is how we place central lines now in the operating room for an elective cardiac surgery case. So so we have an internal jugular vein and a carotid artery. So the object is not to hit the carotid artery, and as we saw in that X-ray, right? And so you can use a short axis view. Short axis means you're slicing the image in the short axis, I guess. I don't have an easy way to describe that. But long axis means along when your probe is parallel to the vessel. So if the internal jugular vein is going this way, your probe would be like this. And in a short axis view, your probe would be perpendicular to the vessel. That's what I'm trying to describe here. So what you can use either view, but this when you use an ultrasound, you can actually see your needle and wire going into the vessel so that you don't backwall it and hit the carotid artery. That's the most common complication with an IJ placement, is that you have a hematoma or a pseudoaneurysm related to the carotid artery. Most of them are benign and will hold pressure, but you can really reduce the amount of those, especially before you're doing a pump case, and you just don't want to cause unnecessary issues if you don't have to. So take the extra, and I don't even think it takes any longer, to be honest. If you've got everything set up, this should be very, very quick. And you can use it to confirm two things: when the needle goes in and after the wire is placed. You can use the long axis view and the short axis view to confirm you're definitely in the vein and that you have not traversed this boundary into the carotid artery. So that's why I think it's helpful. Now, when we go to the groin, this is the view that you want to obtain when you look at the groin vessels. This is called a Mickey Mouse view. So you can see the outlines, and these are the two ears over here. So and so the femoral vein is right in the middle. Veins are compressible, so you would see that with the ultrasound probe, that it flattens when you push down. And this is the saphenofemoral junction. So when you place ECMO cannula, you want it to be just slightly above this, the saphenofemoral junction. But really, you can place that lower, but that's just the point where the vein is the largest. So you can put a good-sized cannula without having to worry about things. And so you can see here, this is the superficial femoral artery, and below it is the deep femoral artery. So and so for ECMO cannula or even for central lines, you might want to go higher than this view to the common femoral artery, and you would want to see where these two merge together into the same artery. And that's important because you don't want to pass point and place your ECMO cannula, balloon pump, impella into the profunda femoral artery. Happens, and we often get called to cut down devices that are placed in the wrong place. So it's been known that with blind sticks, you'll place things into the profunda. It can be fixed, but it's just much more of a mess. You can't really hold pressure on the profunda femoral artery at the bedside. It almost always results in a hematoma or pseudoaneurysm when you pull the device out. So that's why I think it is important. You can see how easy it would be to pass point that and go to the wrong way. So. And you still have to use anatomy. You still have to know, where the inguinal ligament is, where your pubis and your ASIS is, to know where to go. But I think it's just so much easier when you do have an ultrasound in a controlled situation. So, and so in this short video is just highlighting that you can use the needle and the wire to make sure that you're staying within the lumen and haven't gone past into the carotid artery, which is sitting right here. So. Okay, so that's basic ultrasound principles. So, but you can use it virtually for anything. We can also use it for vein mapping for bypasses. On patients that I'm worried, now we do that in the office on our own, and just because it takes about 1 minute to do it, and you just really have a good understanding, especially if you're concerned they might not have good veins. And so echocardiography Keep in mind, you're getting a surgeon's perspective on echocardiography. I am not a professional ultrasonographer, but I know enough to where I can make sure that whatever I'm doing is safe, and so that's what I use it for. I just kind of learned on my own how to do these after seeing some of the cardiologists do it. But for a transthoracic echo, which is called a surface echo, where we place the gel and the probe on the skin right at the chest. So that one is actually quite easy to learn. You could figure out how to learn this online, actually. That's honestly how I learned how to do this. So there's only 3 views that you need: parasternal view, apical view, and a subcostal view. For my purposes, I only even just use 1 or 2 views. I just need to see some very basic features of the heart. So, I'll use whichever one will give me that. So when you do this exam, it's best done when the patient is leaning towards the left side. So sometimes we'll put a wedge or a pillow underneath the right side of the patient to help out. So. And so this is called a parasternal long axis view, and so this has some images to highlight what that looks like. So you're looking at this at the heart in the long axis. This is the apex, the septum, and this is the aorta. So you get a pretty good view of the right ventricle and the left ventricle. So that's what this is showing. This is the right ventricle and the left ventricle over here, and the aorta going here. This is the left atrium, and so this is done by placing the probe just like it's shown here with the probe indicator pointed towards the right shoulder. So and you can rotate the probe slightly to either way to get the right image. And sometimes this may not be the best view based on the body habitus, but you've got to get in between the rib spaces and sometimes underneath the breast to get this view. So. Okay, and this is a short axis view, so you can tell the probe is perpendicular, right? The heart is just like this, so the probe is now placed this way. So that's why it's called a short axis view. So this is like a donut view of what the heart looks like, right? And so this on this crescent at the top, the dark crescent, that's actually the right ventricle, and this thicker donut is the left ventricle here. So you can tell it's very muscular, actually looks fairly healthy, and so I don't think I have this on a video actually, but yeah, it's just to highlight what the short axis looks like. So you can tell if there's regional wall motion abnormalities of the various walls, the anterior wall and the inferior wall based on what you're looking at. So one more thing to point out with a surface echocardiogram. So it may seem like a simple principle, but it's good to know when you look at these pictures. How do you know what you're looking at? So the probe is on the skin. So the structures that are the most anterior of the heart are going to be closest to you. So the right ventricle is going to be the closest to you. The left ventricle and the left atrium are the furthest away from you because they're the most posterior structures. So that's why you have this cone, that's the ultrasound image. The most anterior structure is the right ventricle because that's closest to the surface of the skin. So that's how you can tell, are you looking at a TEE or a transthoracic echo, is use your clues to kind of see what's the thing that's closest to the ultrasound image cone. So, and apical. Probably my most favorite view because this is generally all I need to know if the heart's working after, even in the sickest of patients. So basically you just take the probe and you point it towards the apex of the heart. So, with some small adjustments, you can get a nice 4-chamber view. You can see the left ventricle and right ventricle. And if they're distended, if you can tell, you can have a pretty good idea of the contractility with that as well. And again, we're on the surface of the skin and we're pointing the probe right at the apex. So that's why the apex is right here. So this is outlining the path of the probe. So that's how you can tell this is a transthoracic echocardiogram. So I tend to keep it pretty simple, and I'll show you guys some of the most common things I look for. This is a subcostal view. We don't often do this because there's chest tubes right in the way. This requires you to be right below the xiphoid process. You have to push down to get just below the sternum, so you can look at the heart. But if they don't have chest tubes in place, you can actually get excellent views. This is the liver right over here. Sometimes that gets in the way, but you can get a pretty good idea. This is the right ventricle, and the left ventricle is over here. So, And anyway, so I think if you if you're in a practice and you have minimal resources, this is I would encourage you guys. This is quite easy to learn, and so these are the only views I would care about at the bedside if I'm doing it. I do this apical 4-chamber view just to make sure, is there a pericardial effusion or not, and that's all I want to know. And then the other thing I would like to know, and that helps me determine, is there any concern for tamponade? Is there anything compressing the heart? And then the second view, so short axis view, helps tell me, is there good contractility of all the walls? Am I worried about any of them? Am I worried about any of the grafts? This looks great. So for me, this is good enough. And I could get these two at the bedside myself. So it saves a lot of time and makes you self-sufficient. But if you're a nurse practitioner or a PA even, and you work in the cardiac ICU a lot, I would encourage you to try to do it. It's really not as difficult or intimidating as it seems. So I don't actually measure anything when I do this. I just want to know, is something going to kill the patient overnight when I'm trying to do this. So. And this is just another example. So you can tell in this view that the left side of the heart significantly dilated, very thin left ventricle. So this patient has heart failure, and you could also assess their volume status if you did this at the bedside. They're significantly volume overloaded. So this patient probably needs to get volume off in some way. And the left atrium is even chronically dilated. It's much bigger than all those previous pictures that we just went over. So, and the right ventricle actually looks fine. So it's squeezing well. It's not that big. So this is primarily left-sided heart failure. So we don't have to get, it's hard to encompass all of the different details about an echo in this forum, but that's really, I just wanted to highlight the utility of it, especially as we get more and more comfortable with using it at the bedside. So I have this here to show you how the TEE views are different. So just to keep the orientation very simple. So transesophageal echocardiogram, we put the probe down the esophagus, and the views are obtained from the mid-esophagus, distal esophagus, and then there's also gastric views where the probe sits right here. And that's important to know because that's giving us various views related to the heart. So, but there's really three of the most basic ones: mid-esophageal, distal, and gastric views. So, and in these cases, the probe is closest to the left atrium, closest to the back side of the heart, right? Because we're no longer on the surface, we're on the back side. And so that's why when you look at TEE images, the left atrium is over here because this is where the probe sits. So the images are basically flipped in that sense, and the apex of the heart is going to be the furthest away. So, and you can get very sophisticated views, much clearer pictures with TEE because there's not many things in the way. So, but of course you would need anesthesia or your cardiology colleagues to help you with most of those. So, but I just wanted to at least give you the orientation so you can tell, what am I looking at, a TEE or a transthoracic echo? I think even if you just know that, and so then that would be a good thing. So from a practical standpoint, why are these important? So for cannulation for ECMO, this can be invaluable in a controlled setting. This is the safest way to cannulate if you have fluoro and TEE at the bedside. So whenever we're placing the wire at the bedside in the femoral vein, you can see the wire go from, this is called a bicaval view on the TEE. So when we have this is an excellent view that the ultrasonographer would give us. You can trace the wire from all the way from the IVC, right atrium, into the SVC. So you have a clear, straight shot for cannula position. So that's kind of the gold standard when we cannulate someone for VA ECMO. So and it gives you added confirmation that your wire is not tangled up in a hepatic vein or somewhere else. So so you can kind of rest assured when you have that. So this bottom picture shows what it looks like when you actually do have a cannula in place. So you can tell. You can see both walls of it, and that the tip is right up in the SVC. Your cannula isn't going into the right atrium or the right ventricle. It would be curved downward over here if that were the case. So that's perfect positioning, and that's how we use TEE in a practical setting to help us do what we need to do. So if you have that and fluoro, that's about all the imaging that you need to be able to do it in a safe way. So sometimes you just have one, and you can still do it. TEE specialists, cardiologists can now, they've just gotten so much better at 3D views and everything, so they can help us plan out operations as well. You know, when we do this, this is the view of the mitral valve. This is a surgeon's view or the left atrial view. So this is actually how it would look if you pretend we're sitting in the left atrium looking out at the valve, and the hole would be the left ventricle. So this is the view we get when we are doing mitral valve surgery. You see the anterior leaflet on the top and the posterior leaflet on the bottom. And the reason I put this here is just to highlight how helpful it can be, because when we have a view like this, we can actually see the regurgitation coming from which portion of the mitral valve. So that helps us plan out the operation, about what we need to do. If we need to do leaflet resections or cords or replace the valve entirely, or if it doesn't look that bad. So this valve looks normal actually. So, but they've just gotten so good at it, it can really help us look at these things. So, okay. And we're going to have some stuff on CT scans, and that's going to be the last real thing about this. Any questions on ultrasounds, echoes before we move on?
Not on echoes, but on mitral valve repairs. I'm never doing any. I'm not doing any more.
Okay.
My last experience with a mitral valve repair was the proverbial mitral valve repair hokey pokey, and I have decided that I'm done.
Yeah.
I'm old enough. I've been doing this long enough. No more mitral valve
Sure.
repairs. A mitral valve replacement, it's already planned as a replacement.
Sure.
Fine, I'll do it.
Sure.
A mitral valve repair, almost inevitably, it's repair it, look at it, repair it, look at it, repair it, look at it, add this stitch, add that stitch, repair it, look at it, trim this, trim that, repair it, look at it, close the atrium because the argument is, well, the heart's distorted. We need to close it all up, come off bypass. The MR is worse than it was beforehand. Go back on bypass, open it up, take the repair out, take the ring out, and replace the valve.
I like.
Why do you all do that?
I like your phrase, mitral valve hokey pokey. So.
Mitral valve hokey pokey. I'm not doing it anymore. That was it. My last one of those was the other day. It was this week. I'm not doing anymore.
Okay, fair
That's
enough.
it.
Fair enough.
So if you get a mitral valve repair, somebody else's Melissa, Min, doesn't matter who. And if you do a mitral valve replacement and it's just a replacement, I'll come in and help you.
Yeah. I hear you, and so it's definitely frustrating. So, but there are places and there are people that's all they do, and so and if they're a center that just does that, yes, it can be pretty helpful. And anyway, but I agree. It's not a fun one most of the time. So, so CT scan. So this is basically like looking at X-rays in a more advanced way. It's a series of X-rays, or slices in a loaf of a bread, if you will. You can cut them in various ways, and so we're going to talk about some basic things about how CT scans are, about how to look at them, and just some basic orientation. So the scans, CT is computerized tomography. It looks at things of various densities. It's very similar to X-rays. So white is bone. Metal and blood when you use contrast. Anything with contrast lights up as white on a CT scan, and so light gray and dark gray are all the other things, all the muscle, liver, organ, subcutaneous tissue, and the black, of course, is air or the lungs. So and so I think it very closely mirrors X-rays. So which is nice. It keeps it similar. So MRIs, whole different story. They like to flip all of that based on the type of phase it's done. So we're not covering that, and for today. But I really think about CT scans. Whenever you see them, most important thing to remember is the orientation. But it is like slices in the loaf of a bread, and so most common are axial cuts. That would be this loaf of bread, basically, because if you have a patient, their head is on one end of the loaf and their feet are on the other. When you take slices that are perpendicular, those are called the axial cuts on the view, and so that's what I'm trying to show over here. And in those views, those are the most common ones we use. This is the spine, so this is posterior, this is anterior, this would be patient right, labeled by the little R, and left, a patient's left as labeled by that little L. So, and we're going to go through some more detail, but purpose of this slide is to show that there's 3 different ways to take a look at it. So that's axial. Coronal is if you had a patient standing up, and if you were looking at them as if they were standing up right across from you. So the head is going to be up there, and the feet are going to be down here. And this is the patient's right and patient's left. So sometimes I think, oftentimes I think this is a very helpful view because it helps us kind of decide, okay, which rib space are we going to go to when we do a procedure? You can actually count them and plan out your operation pretty well. So, and so I think it's important to look at a scan in more than one type of view because that's how you really get a complete 3D picture in your mind of how things look. So, and so because you can be fooled with just one view, and it's kind of like reading half the story. If you just look at one view, only the axials, you're only reading half the story about what actually things look like. So you have sagittal views. These are probably most helpful for aortic cases, and because you can actually and so in the sagittal views, you have slices that are in the other orientation. Patient is standing up, but you're kind of looking at them from the side, if you will. So this is the back, and this is the front, and so this is helpful for spine cases also, but also aortic cases because you can look at all the branches that are coming off of the aorta, and if you had an aortic dissection or atherosclerosis of the aorta, you can see which branches are affected pretty easily and how bad it is from a view like this. So I would encourage you guys, when you look at them first, it's slow at the beginning when you're first getting oriented to everything, but try to look at all 3 because they'll give you a very good idea of what you're dealing with. So. And so there's several different types of CT scans based on the contrast and the phase that's utilized. They can get very sophisticated. On this slide, I'm keeping it just very simple for the most common ones we use for cardiovascular related things. So there's CTA or CT angiography. So this is different from angiography and fluoroscopy, which is what vascular surgeons and cardiologists do. And so in this case, you give contrast. And you're using a CT scanner to shoot that angiogram. So in this case, IV contrast is utilized. They put the contrast through the IV, and the scan is timed for the arterial phase. So they actually time how long it would take for that to get to the heart and pump out through the arteries, and that's when they shoot the pictures in the CT scan. So this is what you need when you have an aortic dissection that you're looking at, mesenteric occlusive disease or atherosclerosis in the aorta that's affecting the gut vessels, peripheral arterial disease, or even coronary disease. There's CTAs of the coronary that are getting so sophisticated and better that they're actually getting pretty close to angiograms as far as being able to detect the disease. So it actually does help, and it gives you information on how calcified the vessel is, which you may not know on an angiogram anymore. So and so some people even say it's almost going to be something that we start doing in conjunction with traditional angiograms. That's how detailed they've gotten. So, and there's CTs with IV contrast that are timed for the venous phase. This is the most common scan. So this is what everyone typically orders. And so it provides an image of most things in the chest or the abdomen. It also lights up the arteries and the veins at the same time. And so, but an arterial phase is specifically timed for diseases of the cardiovascular system. So, and you can do that to even more of a higher definition if you're looking at just the heart for scans that are gated for the heart. And so now they even have 4-dimensional scans that look at the heart and how the valves open up and everything like that with contrast. So it gets very fancy very fast these days. So, and CT scans with oral contrast, they use gastrographin, and that's given for GI tract evaluation for esophagus injury, small bowel obstructions or perforations or ileus. So and so barium is only used for fluoroscopy. It's very radio opaque, so you can't use it for CT scans. And so ask me how I know. And so, but that's yeah, everything will just appear super bright white, and you won't be able to tell what's what. That's why you don't use barium. So, and okay. Contraindications for these, so you have to know what you're ordering and what the reasons not to order these are. So severe contrast allergies, these are actually common. Common enough to where you're going to have to deal with it. So if you order it, look out for shellfish allergies in the patient's history, or sometimes they will know if they have a severe contrast allergy. So that means you've got to do a 24-hour protocol on pre-medicating them with steroids, Benadryl prior to the scan. So every institution has their own protocol on how they do it. So it can even be done outpatient, but most often we see this as an inpatient type of thing. So lack of good IV access. You need at least, for especially CTAs, you need a good IV in the antecubital fossa. They won't accept certain smaller gauge IVs. Also depends on your institution, really. Obviously, if they're unstable for transport, most importantly, if they're high risk for aspiration when supine, you should really reconsider if they need that scan. So I think that's under-recognized, by the way. So I think there's a lot of bad judgment when it comes to ordering these related to that. If someone is obviously going to aspirate and they can't protect their airway, they're not intubated, you should really reconsider. Bad things happen in CT scanners. If you work in a hospital, you've heard lots of code blues in CT and MRI, and it's most often related to something like that. So. So when you look at these, you should look at it in a systematic approach, just as how you would for X-rays. Don't worry, for this one, there's not a lot of quizzing. It's just too much information to really go through in a short amount of time. But this is how I learned how to do it for trauma purposes. So it's kind of second nature, but it's I look at the cardiovascular stuff first. I'm biased. Look at the heart, aorta, the branches of the aorta, and run off to the extremities. So that's what I look at when I do my first scan through for the axial views. Second pass through, you would look at the solid organs, the liver, the spleen, the kidneys. For trauma, I was looking at seeing if anything is injured, and so or if anything has holes in it. That's what you want to know. And then third, look at bones. If you're in a trauma setting, seeing if there's any fractures. You do have to put it on a bone window, so that way it's specific for the for looking at fractures and finer details. So, and then soft tissues, you're looking at hematomas, fluid collections, any abscesses that might be present. So, and based on what you're targeting, you pick the appropriate phase, but then you want to look at every view that you can to get a full idea of what you're looking for. So it requires some patience. You have at the beginning, you do have to kind of play around with it, so that way you can get comfortable, and then pretty soon you'll be able to zip right through it very quickly. What's a CT scan good for? Well, we refer to the CT scan as a circle of truth, right? And whenever you have a question, emergency room, you go to the circle of truth before you come out into the hospital ward, right? That's unfortunately the classic mantra, but it misses a lot of things. It's not good for diaphragm injuries, bowel perforations, carcinomatosis. It can't pick up if there's disseminated cancer on the pleural or peritoneal surfaces, even if it's a lot, just because those lesions are small. They're millimeters, so it won't pick that up. So at least most often. So that's why laparoscopy or thoracoscopy will pick that up, but you won't see that on a CT scan. So something like necrotizing fasciitis, that's the clinical diagnosis. That's also CT scan isn't going to pick up on things like that. So and so anyway, so you have to know the limitations of whatever it is that you're using. So. Okay, so I'm going to scroll through just a couple of examples. Let me just see. How much time do we have? Just want to make sure.
16 minutes.
Oh, okay. I think it'll be perfect. And so this first example, so this is a non-contrasted scan. So you can tell because the blood vessels are gray, right? And the bones are white. And everything else is a shade of gray. So there's no contrast. There's no oral contrast or IV contrast that you can that you can see. So so anyway, this is so you should be able to recognize that when you see this scan. And so I'll go through some practical things about what I would look for when I see these scans, because when you're looking at patients and you don't know much about them, you can actually use these to your advantage to know a lot of information before you've even seen their history. So and so I've got some practical examples on how to go through that. So you can tell they've got some coronary artery disease. They've got some calcification of the. You can tell right here some calcification. That's the left main coronary artery, and so And you've also got some disease of some calcification of the aortic annulus, but not too bad. And you have calcification of the right coronary artery here. That's this one right here, in between the right atrium, which is here, and the right ventricle, which is right there. So you can tell that just before you've even seen them. They've got some coronary artery disease, and so their liver has smooth edges, does not look cirrhotic to me, so that's good. You can see nice smooth borders. It's not lumpy bumpy. Their stomach is filled with stuff, so makes me question, why we did this scan on a full stomach in a patient. So could easily vomit. That's a lot of food in there, actually. So, and so their spleen is normal in size. Again, tells me they're not cirrhotic. So, and so going down here, you can tell they've got some calcification of the aorta. That's not bad though, but there's some disease there. Doesn't seem that horrible, honestly. And you've got some disease in the iliac vessels. You can tell there too. That's that stuff that lights up white. And same with the femoral vessels. There's just a little bit of calcification, but not bad. So you can tell all that based on a non-contrasted scan. But just so you guys have seen the difference, a scan with contrast, you just get a much better view of what's going on. So in this case, you can see the bright white is in the vein actually, and so you can tell right here. So where the contrast is coming out. This is in the innominate vein. You see, it's super white, almost blinding your ability to see things, and it's going to go to the SVC because that's where the contrast is going, and it's also lighting up all the blood vessels. You can even tell that the tissues are more well defined because there's contrast. You can see the grays better. It just lights up more, and that's why you use contrast. So you can better define some things and get things that you would otherwise miss. So anyway, so scrolling through this, I would look at there's the 3 blood vessels for the aortic arch, ascending aorta, descending aorta, pulmonary artery, looks normal in size. There's no filling defects. Pulmonary emboli, follow the descending aorta down, and you have celiac artery first. That's right there. SMA, IMA right there too. And so for those of you that might have missed it, I'm just looking at the anterior surface of the aorta for the branches that come off. You can the renal arteries are right there, the left and right. So as we're scrolling through, kidneys are healthy. You can tell they take up contrast pretty well. They actually look pretty nice, and so they take up 20 to 25% of the cardiac output. So it's good that they light up well. And the peripheral arterial disease is not that bad. So you can tell all of that just by looking at this, and so anyway. But you've got to have some practice in just doing this from time to time. So I'm going to go through some examples pretty quickly, just of some abnormalities. That was a relatively normal scan on a patient that I'm doing a cabbage on later this week. So their main issue was coronary artery disease. So this is a liver laceration. So this is what it looks like when you have contrast. You can tell the liver lights up very well. It's very healthy otherwise. It's smooth. But you can tell this is disrupted. There's a crack in the liver here, crack in the liver here, and there's various layers of gray that are all out here. And so how do you know what's blood and what's not? So the thing that lights up, whatever's lightest like this is most often blood. It almost looks the same density as the liver. So that's how you know that's blood. This type of fluid, that's probably a small pleural effusion. That's just on the right side. So that's much darker, so you can tell that that's most likely not blood. What the radiologists do, they measure something called Hounsfield units to look at the density of this type of fluid, and they anything over 50 to 70 is more consistent with blood. So anyway, but the way we could tell, not not using any fancy tools, is just that, hey, that looks more like the liver than anything else. So that means it's got to have some blood in there. So that looks pretty fresh actually. So okay. This is what a cirrhotic liver looks like. So that's when I was referring, earlier that that previous liver was nice and smooth. This is a lumpy, bumpy liver. Spleen is enlarged. So this patient has cirrhosis. So you can tell that just by looking at the scan, even before you've laid eyes on them. So you can even tell how bad the kidneys are. Even with or without contrast. So medically, chronic kidney disease looks like this. Kidneys are all shriveled up. and they've got a lot of fat stranding around them. And the normal kidneys have smooth borders, take contrast very well. This is without contrast, but still, you get the idea that clearly this is probably a much older patient, and so with some chronic kidney disease, this is probably a much younger patient. Those kidneys look nice and healthy. So this is what something like this is what appendicitis would look like, and so you've got an appendicolith or a fecal stone that's there, an inflamed appendix. The reason I put this there is just to show what fat stranding looks like. That's what this hazy stuff over here. It's not smooth like the edges of the muscle right here, right? You can the borders are very obscured. That's what the radiologist called fat stranding. That refers to inflammation. Can also be seen with edema. So so anyway, that's a common term that you'll see them use. But anyway. So, and then lastly, we'll mention some things about aortic dissections. So, for our purpose in CV, this is the most common reason why we use why we use CT scans. And I think it's if you're in a practice where you have a lot of aortic dissections, it's very good to get good at these CT scans because they're invaluable to operative planning and just knowing what things are going to happen. So in an aortic dissection, you have a tear in the lining of the intima of the aorta. This occurs at the ascending aorta most commonly, but can be really anywhere. And so this is what we call a type 1 aortic dissection. It starts here, ascending aorta, and it goes all the way down the aorta to the iliac vessels. So, and terminology that we use to describe how the blood flow is affected is the true lumen and the false lumen. The true lumen is where blood is supposed to go before that aortic dissection happened. This is bordered by the intima here and the intima here. So blood comes out of the heart. It's supposed to go to the true lumen, and that's how things are perfused in the body. But because you have a tear, blood is also going to go in what's called the false lumen. So this is where blood is not supposed to go, and essentially this causes obstruction and malperfusion. Because you have the false lumen that's filling up and obstructing flow down all of the other arteries and tributaries of the aorta. So that's why it's important to know that pathophysiology, because when you take a look at the scans, this is what you see. So this is how we use contrast to differentiate them too. This is the true lumen. It's very well perfused. You can tell by the amount of contrast. This is the false lumen. It's more sluggish, right? And so that's most often the case. But you would have to make sure by looking at the whole picture. But you can also tell here that the descending thoracic aorta lights up well, and so the dissection doesn't propagate all the way there. It's mostly isolated to the ascending aorta and maybe the arch. You'd have to look at all of the images to really know. But that's how you would follow this through all of the pictures, highlighting all of the branches of the aorta, looking at the celiac, SMA, IMA to know what's malperfused and what's not, and what is the dissection involving. Now this is what it looks like when the dissection is involving the descending thoracic aorta too. So again, you would follow this down and up to see the extent of the injury and what malperfusion you can expect to have, which organs would be affected, so to speak. So. And now they've gotten very fancy. There's 3D imaging of these, so you can plan out. You can actually rotate these pictures. This is an example of how it looks in the chest. This is the aortic valve, aortic arch, the head vessels here, innominate artery, left common carotid, left subclavian, and this is the arch, aneurysmal, large dissection here, and that's this flap is what would be in between the true and the false lumen. And they're showing how this extends to the abdominal aorta, how that would perfuse the kidneys, and it splits all the way down here, affecting the iliac. So this is a pretty big aortic dissection. So, and so anyway, but you would use these scans now. The radiologists help us with these 3D pictures so we can better see what to expect when we go to the operating room. And so they've gotten great with these. They even, for elective non-aortic dissections, but for lung pathology, they'll even use these to make like 3D printed models, so you can plan out a surgical oncologic resection of complex lung tumors and things like that too. So it gets very, very advanced. So I just wanted to highlight how we use it for mostly aortic dissections, though. So that's it.
Okay, very good. Very good. Thank you very much. We appreciate you very much.
My pleasure. Any questions about
Any questions from our studio audience or from our online audience? Yeah, I know. I forgot. We have. I'll tell you what. We got a lot of participation. A lot of people here, but nobody. Everybody is being very timid today, and not wanting to ask anything. But you know, I will ask. You know, when you're doing a CT, so if you want to go back to the image.
Sure.
Your CT without contrast, and you're scrolling through that.
Mm-hmm.
Can you start with like some point, the head, the if it's a chest CT, I don't know what the CT is, CT up, but where do you start? And then as you're scrolling it, what do you see coming in? Can you maybe just give us a little detail on that?
Sure. So I start at the head, and that's how most scans are oriented for you. So when you open the images, this is how most institutions will orient their images. So this is the head, and you can tell that because you also see the trachea up top, and you can start to see.
So can you point to that for us?
Yep. So this is the trachea right here, and you can tell this is the towards the apex of the chest. You're just starting to see the lungs here. That's how you know, and you also see some blood vessels. You might not know what these are yet, but this is that's how you can tell you're you're just north of the heart and everything else. So and so anyway, and you can also see that this is the scapula over here. So that way, you know, you're still kind of further up north. Mm-hmm. So as we slowly go down, you can tell. Okay, now you're starting to see the aortic arch. The lung fields are clear. You've got the sternum up here, so you're kind of in the upper mid chest over here, and you've got the spine over here as well. So, and this is the trachea, and the esophagus is sometimes hard to see, but it would be right over here. So, and then as we keep going down, so you can see that this is the carina. That's the right mainstem bronchus, left mainstem bronchus, esophagus, ascending aorta, descending aorta, pulmonary artery right here, and so those are the heart structures that we look at, and then we'll keep going down, and so you can start to see this is the diaphragm on this side, and this is the diaphragm and the liver actually already appearing on this side, and so that's how you know you're at the base of the chest, and so probably now you can see it clearly. There's a donut-looking structure. That's the esophagus. And this is the aorta. They're both very close to each other. Sometimes the esophagus gets kind of squished by things. So, and so now when you go to the abdomen, you can see liver over here, stomach over here, and spleen over there. So, and then the two kidneys at the bottom. So, as we pointed out, there's some fat stranding. You can probably tell they've got some component of chronic kidney disease. The borders aren't as smooth as that young patient that we saw. So those are the kidneys. These are all the guts, the intestines. So, and colon looks more like what you have over here. It's that soap bubble type of appearance typically, and this is small intestine, typically fluid-filled loops, and they're smaller in their diameter. So that's how you know what those things are, and then down here, bladder, rectum, and you can start to see the this is the pubic bone coming into view over there. So and the femoral heads. So yeah, that's how I start, head to toe. And you can when you're looking at these, take your time. You can look at just the bony structures first, just the solid organs first if you want, just so you know what you're looking at. And you have to take a look at a lot of normal ones of these also. So it's even if the scan is normal, take a look at it. That way you are more comfortable, and that way when you do have an abnormal one, it'll make more sense to you why that looks that way. So
Kelvin says congratulations. He was very happy to have participated, to listen to you today. He learned a lot.
Okay. All right. Great.
So you're getting some positive feedback.
Good.
Very cool presentation from Professor Campbell. So good. Anybody have any questions? You can always call in. That phone, if we ever hear that phone ring, I swear, you'll see me do some flips. So if anybody wants to call in, they're welcome to do so. If not, any parting thoughts? No?
Very good.
Okay, very good.
All right. Thank you,
Thank
guys.
you very much, Dr.
Thanks
Patel.
for
We
your time.
appreciate you. And we will see you tomorrow morning. Is that right? What time tomorrow? 8 a.m. 8 a.m. And you're going to be talking about waveform analysis, right? No. What are you talking about tomorrow?
Regulation of cardiovascular.
What's the title?
Regulation of heart and vessel.
What's it say on there? I can't read it.
Regulation of cardiac and vascular function.
There you go. Regulation of cardiac and vascular function tomorrow morning with Vicki. And then I'm giving a talk actually afterwards. Mine is going to be very short. It's going to be fun. And it's going to be basically, what does a perfusionist do? There's a lot of ideas out there. A lot of people say all kinds of things, but that's just going to be 20 minutes, but it's going to be entertaining. If you want to be there for that, that'd be great. Yours is going to be very interesting and very good and very useful for taking care of patients. Mine is going to be more appropriate for the cocktail hour, which is what we're going to go do now.
Okay, great.
We'll see you all later. See you tomorrow morning.
Bye.